Good afternoon, everyone. It's good to see some of you. I have my screen set so I can see some of your faces.
Good afternoon.
Good afternoon. My name is Ann Gray, and I'm gonna introduce myself in a little more depth in just a minute. But first of all, just a few housekeeping items for this presentation. We're gonna have a Q&A at the end. So if you can hold your questions, we'll go into a more informal setting. I'll unshare my screen so we can just have a conversation. So what I'd like to do to start with is get a little sense of who you are. So if you all could unmute and share, your name, what your role is, organization, if you're a clinician, that will just help me with some of the content that we're going to be talking about today. So if we could start that would be great. Just jump right in.
Okay, my name is Delolve. Okay. Yes, my name is Delolve. I am a problem gambling prevention specialist for the Council on Compulsive Gambling in New Jersey. As a social worker, I travel because I'm bilingual, so I travel the whole state, but I basically concentrate a lot when it comes to youth.
Great, thank you.
Presentations, thank you. Do a lot of school presentations, a lot of presentation to parents, just bringing parents up to date as far as some of the techniques and some of the stuff that goes on with the kids, and basically do a lot of prevention with youth.
Great, wonderful, thank you.
You.
I'm Margaret Ferris with Coastal Treatment Service.
Hi, Margaret. You're muted. I can't hear you. You're muted.
Oh, sorry about that. It's good to see you. We're a clinic that provides outpatient and intensive outpatient treatment services for problem gamblers and their loved ones.
Great. Good to see you, Margaret.
Yes.
Anyone else want to jump in and share who you are? I'm looking at the participants. Gary, Alexandra.
Gary has shared that.
I'm Troy Green. I guess I'm now a substance use disorder professional. I refer to myself as a CDP up until somebody changed it. And I'm also a certified problem gambling counselor through Evergreen Council on Problem Gambling. And I work out of Tumwater, Washington.
Great.
And we've got a practice there. I've been doing problem gambling counseling since 2007, I think. So got a little bit of time in it. So
great, thank you, Troy. Let's see. I don't think we've heard from Rob.
Hello. I'm actually with the Evergreen Council on Problem Gambling.
Great, nice to meet you, Rob. And then Alexandra. Okay, we'll go ahead and get started. I think I have a sense in general who's in the room, so let's get started. All right. Well,
I'm sorry, I didn't go. I was on a phone call about a client. I'm Karen McCoy. I'm a SUDP counselor with Cowlitz Tribal Treatment here in Vancouver.
Great, thank you. All right. Thank you very much for sharing. That's just helpful for me in terms of what we're going to be talking about today, just to know who the audience is. When we get to Q&A, that will be really important. So let me tell you a little bit about myself. I am currently the program supervisor for suicide prevention and behavioral health at OSPI, which stands for the Office of the Superintendent of Public Instruction. I have 35 years of service as a public school educator, teacher, counselor, principal, and district administrator. I always tell people that's why I have gray hair. It would be the principal part of that. I was the former problem gambling program manager at the Washington State Healthcare Authority. And I was actually, I've worked with several of you. I was nice to see some familiar faces. I actually worked as the problem gambling program manager when we were under DSHS, the Division of Behavioral Health and Recovery. So currently Healthcare Authority. And I do have personal experience with gambling addiction and recovery. I am in recovery from problem gambling. So I do share that fairly openly, and that can be part of our Q&A as well when we get to that point in the program. I was also privileged to serve as an ECPG Evergreen board member in the past as well. So I have some experience with a great deal of content matter actually, but relevant to today. I'll be talking particularly specifically about suicide prevention with respect to families and youth. I will be very open to, again, in Q&A, to talking specifically about problem gambling as well, if that is, something that you have questions with related to suicide prevention or not. And then, of course, anything related to the world of education, which I currently live in. So that's just a little bit about me. So I want to ask you, and we can use the chat feature for this just because it'll probably be easier as far as time. On a scale from 1 to 5, what is your level of self-care? And as clinicians, you all know that this is critical during a pandemic and a unique and somewhat challenging holiday season. If you could type in the chat one word that describes your emotional state of being today. And I will read these as they come in. Content, 4, self-care, engaged, relaxed. Okay, I like that. I like relaxed, I like engaged, and I definitely like content. Great. All right, so this is difficult content at times, so I want you to be sure that you take care of yourself as we go through this presentation. Do whatever you need in terms of self-care. Really, really important. All right. So, an antidote to stress and fatigue is self-care. That's why I started with that little activity. And here's just a little slide with 8 dimensions of wellness. This is from SAMHSA, and talks about emotional coping effectively with life, creating satisfying relationships, the environmental dimension, good health by occupying pleasant, stimulating environments that support well-being, intellectual, you're recognizing your creative abilities and finding ways to expand knowledge and skills. Physical, recognizing the need for physical activity, diet, sleep, and nutrition. I've noted with many people I've been working with, primarily educators and clinicians in the field, this is really important right now. While we're all contained somewhat, the need for that physical activity. I know I've had to work really hard on doing that, especially when the gym's closed. Diet, sleep, and nutrition. When you're at home, I know for me it's much easier to not eat well, to go for the junk instead of the good. So this is a really important piece. Occupational, personal satisfaction and enrichment derived from one's work. That's also something I think there's been lots of conversation with around during the pandemic. Spiritual, expanding our sense of purpose and meaning in life, whatever that looks like for you. Social, developing a sense of connection, belonging, and a well-developed support system. Now, this has been extremely challenging during the pandemic. And I know working with youth, we really are struggling with ensuring that our youth are connected. We worry intensely, and I know you all in your work as clinicians see this, about the youth that are dropping behind, so to speak, and they're dropping out. We're not seeing them, they're not engaging in, the Zoom classrooms, et cetera, et cetera. Financial satisfaction with current and future financial situations also intensely impacted by this pandemic as the dimension of financial stability. So those are just some pieces to be very tuned into during this time. It's an antidote to stress, and fatigue is always self-care. So let's talk a little bit about your work, and you all are very aware as clinicians that stress, holidays, and addiction, hard, difficult. As a recovering addict, I will share with you on a personal note that when I was active in my addiction, the holidays, I used to call myself a holiday gambler, which is really interesting because I really gambled anytime. But I think that was this permission I gave myself. And so just take note as you're working with individuals that very challenging time for people struggling with addiction or in recovery. It's a time that elicits feelings of guilt, shame, sadness, and regret. I know that I have those feelings many times. In recovery, the feelings have changed. I will say I have a different set of feelings. However, there was, an enhancement of those emotions during the holiday season. And I think I've talked with many people in active in addiction and in recovery that concur with that. Families worry a lot about the emotional well-beings during this time of year. I think there's lots of data and research out there around the holidays and the difficulties that occur, which just lends itself to families being on alert even more so than in general, in terms of worrying about their loved ones who struggle with addiction and or recovery. So let's add COVID-19 to what we're dealing with. And, we're dealing with individuals struggling with addiction and recovery, individuals with emotional distress, and then we add COVID-19. So we have parents and caring adults out there who are trying to do their job. They're trying to care for their children, and they're trying to teach them. And on top of all of that, they are worrying about finances potentially. They may or may not be worrying about their own, caring and worrying about their own parents. And again, as I mentioned, too quickly, because it's very much what we're working with at OSPI is parents are working, teaching from home. And in many cases I was a teacher, and if I had to be teaching my own children while trying to work, I'm just not sure what that would look like. So I have incredible empathy and support for our working, teaching parents. So our teens and our children, our youth, they are worrying about their future. I am fortunate to have some youth advisories, and they have shared with us that they are very worried. This is the adolescent, more high school folks. They are worried about the future. They are not sure, what it's going to look like. How am I, if I'm a junior in high school, how am I going to get through my credits? How am I going to, if I'm a senior, how do I get to, looking at colleges, considering colleges, applications? I mean, it all looks so different. They're very, very anxious about the future. Youth, all ages from kindergarten up, are missing their friends. They're missing activities. They're missing sports. They're missing that connection. I mean, they're missing recess in terms of the simplistic piece of, doing what they do at recess, which is often running around chasing each other. I've had the fortunate experience of supervising that for many years, and they're missing, just that casual engagement that they have. Many of our youth are very anxious about these new platforms. It is getting better. I think, there's with time, obviously, students are becoming a little bit more familiar with these new learning platforms. I have a daughter who's a second grade teacher, and she comes over and talks to me about Seesaw and Google Classroom, and I'm not young, so I'm like, oh, I pretend I know what all of this is. And she has shared with me that sometimes the kids just, they want so desperately to have that engagement again, that face-to-face, and they do incorporate face-to-face small group activities through Zoom, or Google Classroom. But again, many of them struggle. And of course, there's an equity issue here. Many of our kids do not have adequate access to the internet. Some of them don't have the technology they need to have. That's sad and hard for me to say out loud, because that's on us in our communities. We haven't gotten there yet. Many are feeling unsafe, and some of these kids are just flat out worried that they're going to regress. They're not sure if they're going to make it. And I can share with you, some of the conversations we're having at OSPI around, what do we do with the fact that we have kids that are not going to be prepared to move into the next grade. So that's a real concern. They're also experiencing physical symptoms. They're just, I'm sick. And we know kids do that anyway. And we're seeing a lot of that now, the physical symptoms. And this is coming from the Department of Health. They have a family toolbox, and I'll be sharing resources with you towards the end of our presentation. So let's take a look at some forecasted behavioral health impacts from COVID-19. So this is coming from Department of Health. The next two slides are both Department of Health slides. So look at this. If you take a look at this, basically it's looking at reactions and behavioral health symptoms in disasters. Okay, so this isn't specific to COVID-19. And if you look at, you see -6, so before the outbreak, you have pre-disaster. And if you can recall back to January, February, we were hearing warnings. We were hearing, what was going on in China. This is a disaster that's happening in our world. We were exposed to the threats and potential impact. So then we experienced our outbreak here in the United States. And if you look at the next box, which is the pre-post outbreak, and we look at the beginning, we did, if you recall, experience what they are referring to as a honeymoon. And that was where we sensed our communities coming together, people really, looking out for one another. When we had our lockdown shutdown here, people were supporting small businesses, doing everything they could, lots and lots of outreach in terms of food banks and supporting those who were experiencing difficult times with housing. So that's the honeymoon. Okay, so then as you can see, it drops down. And this is where we see disillusionment beginning. And there's a huge drop right about 6 months. And we have surpassed that. And we're somewhat beginning to move out of disillusionment. Of course, with the vaccine, we have some hope that's happening. So this trend will likely continue. If you notice at 12 months, and we will likely be there in reconstruction and working through, we're still going to be potential setbacks. We'll still be working through grief and coming to terms with the reality of what we've experienced. So moving on to forecasted behavioral health symptoms, again from Department of Health. So if you look at outbreak, this chart, if you look at the bottom, you'll see outbreak 3 months, 6 months, 9, 12, 15. And this is a chart of the experience of symptoms strongly predicted by the baseline level of functioning prior to the pandemic. So severity of symptoms, oh, I'm sorry, that's just a Zoom reality. She will stop. Acting out or in, increased aggression, law-breaking violence, substance use, hopelessness, withdrawal, depression, child abuse, intimate partner violence, rates increase, okay, during the outbreak. Then around 3 months, severity of symptoms, depression, grief, and loss of identity, status, job, money, connections. They become significant clinical issues, and I'm sure you've all experienced this. Then around 6, prevention of and resources for suicidal people. and victims of intimate partner violence and child abuse are major focus concern. That's where we are. We are there. And then I've put a nice little circle around holiday season, weather changes, separation or loss of family and friends, compound with financial problems to inform higher rates of depression. So we've got all of that right now. We've got the holiday, we've got the weather changes, we've got separation. We're advised to do our holidays differently this year. And then in the general population at 12 to 15, major depressive disorder, 30 to 60% increase, PTSD 5 to 30 are common. And you can find this information if you want to explore it further on the Department of Health website. So we're going to go into mental health and suicidal ideation. So we've kind of covered some groundwork of where we are in our world. So now we're going to talk more specifically about mental health and suicidal ideation. So is there a difference between having suicidal thoughts and being suicidal? I'm sure that you all know the answer to this question. Yes. Ideation is the term that refers to thoughts relating to suicide. And ideation, as you know, I'm sure, can be active or passive. Passive ideation means the person is having thoughts. They're having thoughts that they wish to die. These are thoughts only. So that would be passive. Active ideation includes actions. These actions mean that they've got their plan and they mean to go through with it. So let's look at understanding it a little more. There's no single cause, and I'm sure you all as experts know this. There's no single cause of suicide. Suicide occurs at the intersection of stressors such as, and there are many more than this is not a comprehensive list. Some of the stressors are a lack of belonging, feeling burdensome, health issues such as depression or anxiety, substance use, a recent traumatic event. So warning signs. Warning signs, my slide is covered up. They show up through talk, actions, or state of mind. So warning signs are an indication that an individual may be experiencing depression or thoughts of suicide. So they may be making plans. They may be feeling hopeless about the future, displaying, severe, overwhelming emotional pain or distress, showing worrisome behavior. And then this list again is some of the warning signs, not comprehensive in terms of there are many, many warning signs. Aggression, irritability, depression, anxiety. These are very common. Loss of interest in what one's usually interested in. Relief or sudden improvement is a warning sign. Just kind of a real change. It's almost that euphoria you may see with individuals you work with. That can be a sign. Changes in sleep. If you have individuals who are actively saying goodbyes to people that they are close to, that is a warning sign. Giving away possessions. Humiliation and shame. Feeling humiliated and shameful, as well as potentially exerting those feelings onto another. And, some of the very overt talking about killing oneself, talking about feeling hopeless, trapped, unbearable pain, increase in substance use. We know this is very much of a warning sign. Researching methods. You may hear clients talking about methods. And stopping normal activities. So, what I normally do, I just don't do anymore. And I have no interest in. And then, of course, isolation. So when working with individuals with suicidal ideation, active or passive, it's really important to consider risk and protective factors. So I'd like you to go into the chat for a minute and list one risk factor and one protective factor. I've got to get my chat box back up here. I will read them out loud as you put them in. Large loss at casino. Risk. From Troy, thank you. Yes. Reach out for help, protective. Absolutely. Any others?
And
No.
I'm sorry, my chat thing isn't working right here.
No worries.
But
you know what? With as small a group as we are, you can unmute yourself and share a risk and protective. That just dawned on me. Yeah.
A risk is I'm not comfortable on the Zoom GA meetings. Right?
Yep, have heard
Get
that.
that a lot. A protective one is, well, then pick an individual to do fellowship with.
Very good. Very nice.
Okay.
Any other?
Thanks.
Thank you, Margaret. Any other examples? Just unmute yourself and share. I just realized we have such a small group that's doable. Any others? Okay, then we'll keep going. So risk factors. Every time I use the chat, there we go. Okay, so a risk factor is a personal trait or environmental quality that is associated with increased risk of suicide. So just note that. The risk factors that contribute to increased risk for suicide. This may be one or a combination of health, environmental, and historical factors. So some are mental health conditions. Individuals with mental health conditions are at a higher risk. Individuals experiencing pain, physical health conditions, traumatic brain injury, exposure to another person's suicide can actually be a risk factor. Access to firearms and drugs. Many times with youth, and I'm sure you all have experienced this, harassment and bullying is a huge risk factor with youth. We see that a lot in schools. Relationship problems, that can be across all ages. Previous suicide attempts, abuse, neglect, and there are many, many more. Domestic violence. I mean, the list goes on and on and on in terms of risk factors. So protective factors. These are personal traits or environmental qualities that can reduce the risk of suicidal behavior. Really important to know that it doesn't mean, they're immune if they have the protective factor. It's just, there's that sense that they have some overarching things going on in their lives, environments, personalities that facilitate, protecting themselves and utilizing skill sets. So examples would be, again, these are skills and characteristics that lessen. They don't make them go away. They may give a person the skills or supports to get through these difficulties. So problem-solving skills, an individual who has intact, really solid problem-solving skills, that's a protective factor. They may be able to work through their issues through going through that set of skills that they've developed. Strong family connections, huge protective factor. We especially see this with youth. We often, as working with youth with suicidal ideation, we make sure to get them connected to their family if indeed that is a strong support system. Community supports. This is where youth are struggling right now, and I'm sure many are. Youth in terms of sports is huge right now. Just connecting to that whole society that exists around sports, competitive sports, club sports, and just informal playing of sports. So that's, and then there's the larger community as well. Individuals who are connected to working with nonprofits, to working in their community, in their church, on and on. Ongoing medical and mental health care relationships. This is a protective factor. If I have a relationship with my provider, physical, mental health provider, that is absolutely a protective factor. That is someone I can reach out to, talk to, and feel safe with. Access to interventions and support for health seeking. So again, I know where to go. I know who to contact. I'm savvy enough to know, where to go to ask for help. This is really important. Restricted access to lethal means. Huge. When the access isn't there, that is a protective factor. And then last but not least, cultural and religious beliefs that discourage suicide and promote self-preservation. And, tap into that if that exists, because that is, again, a very strong protective factor. So I'm looking at time, we're okay. So I want to talk a little bit about the school world. When we talk about prevention, intervention, and postvention, when I say school world, I'm talking about youth, and that's K-12 primarily, which goes to 18. So I want to share what we look at in terms of school support, because it's really important to be supporting our youth with prevention, intervention, and postvention. So I'm going to share with you this particular slide is our response to RCW 28A 320-127, which it does state that school districts must have a plan for recognition, screening, and response to emotional or behavioral distress in students. So here's what we look at, and this can be, these strategies, of course, can carry through the general population. So prevention. I work a lot in my current role in prevention. I oversee 9 behavioral health navigators that I'm going to talk to you about in the subsequent slide, who work out of the educational service districts. And their job, their role is about connecting schools to you all, to behavioral health providers. Because we know, I've been in both worlds now, and education and healthcare don't talk, okay? They just don't talk well. Never have. I'll share an example from when I was principal. I used to put my head down almost in tears so many times with students who needed intense behavioral health support. And we weren't trained as school people in how to get them that help. So we had to call the healthcare authority or, a clinician or, a provider in our community who would come in and try to help us. And then we'd get into Medicaid and the paperwork and the process. And that's where the head would go down and the tears would come. This child needs help now. But I have to go through all this red tape to get that help. So right now, in the midst of the pandemic, we are literally flying the plane and fixing it, because our kids are so in need right now. And schools are emails. I get an unbelievable amount of email every day with, help me connect with this, help me with this issue. Where can I go? And fortunately, we have the navigators as a conduit of breaking down barriers. And I'll share a little bit more about, but I'm getting ahead of myself. I'm starting to talk fast due to time. So prevention. This is where we look at training opportunities for our staff. We want in recognition, screening, and referral of students experiencing emotional and behavioral distress, including substance abuse, violence, suicide, and sexual abuse. In this piece is where we're tapping into the expertise of our staff who are trained in recognition, screening, and referral. This is where we look at plans, safety plans, suicide prevention plans, required training for ESAs. Those are our school counselors and social workers. They have required training in suicide prevention that is dictated in RCW as well. So that's our prevention. Right now, we're going way above what has been in the past. I'll be honest with you. We're rolling out curriculums for elementary kids in suicide prevention. Very sad, but it's a need. Intervention. So this is more how we're responding. This is the response component. Getting into, knowing your risk factors, knowing your warning signs, your protective factors. This is where schools and districts have to be establishing their internal referral system. How and when are we servicing our kids and moving them on to levels of support that they need? Okay, so this is that intervening. This is where the partnerships with community organizations, CBOs, mental health providers are critical. We're tapping into our social support services, and we do lots of MOUs in terms of connecting with providers. We're trying to break down some of those Medicaid barriers every day in this work. Postvention, unfortunately, high need in postvention support right now. I work very closely with Forefront Suicide Prevention. They are very strong in working with youth and are very, very best practice in suicide prevention. We are working with districts right now on protocols and procedures for postvention. That starts with the family communication. Then we move into working with our local community, small. Generally, if there's a death by suicide of a student, it would be working with the school on issues of grief, on crisis planning. We have to then go out and work with the larger community in communication around a death by suicide. And then, of course, there's also the global community and the media that we have to intervene with. So protocols and procedures are huge with postvention. And I'm going to move into talking a little bit about the navigators and some work that they're going to be doing in postvention. So I talked very, very surface level about these folks we have sitting in every ESD, we call them educational service districts, and they're regional. So I'll give you an example for King County. The ESD is 121 and it sits in Renton, but they serve that region. They actually serve King and Pierce. So we have 9 of these individuals and they are across the entire state in a region. And their sole purpose, and they were funded through legislation last session, and the funding came through in this session. Each district hired a navigator, and let me talk about what they do. So here's brief history. I'm not going to spend much time on this slide. You don't need to know the ins and outs of the legislative process that took place to fund this work. But basically, it started as a pilot. With recommendations to the legislator that actually funded these positions through House Bill 1216, school safety and student well-being. And I actually work in that division, in the student support division in OSPI. Hence, part of my role is oversight for the behavioral health navigators. So why do we have them? Something I said at the beginning. We want to increase equitable access to behavioral health care and services for students in need through state and regional cross-system collaboration with schools and communities. Like I said earlier, we don't talk well, schools and healthcare, especially behavioral healthcare. So that's what we're working on. And the purpose of the initial pilot project, which funded them, was to see, okay, is it going to help us with this, break down these barriers, to have one person whose responsibility it is to network with our partners, our school districts, our behavioral health providers, so that we can get the services to our kids. Now, the pilot was strictly based on those eligible for Medicaid. The navigators currently work with all students, private pay, no insurance, Medicaid, across the board. So they're not providers. They do not provide services. Many of them are clinicians, but however, they do not provide services. They are designing, they're using the following principles. Their coordination of behavioral health, coordinating the resources, supports service providers, schools, districts, and communities in their region. They're facilitating partnerships across the multiple systems of behavioral health care services and supports for children and families. They're ensuring the adequacy of systems level supports for students in need through the integration of various models of delivery, collaboration with ESDs, OSPI, district schools, partners, and other stakeholders to increase, again, this is huge, this is their job, to increase access to behavioral healthcare services and supports. So, that was a quick rundown because I want to have time for Q&A, and I want to make sure I get you to these resources. Many of you have seen this. These are the crisis lines. I believe you'll get this presentation, so you'll have this. I use this a lot, and I always make sure I put this in every presentation. And then this looks like a small list of resources, but it is not. This actually has about 30 different behavioral health supports and resources across the region, not specific just to youth. Many resources for families. In terms of, there's some COVID-19 specific resources on that list. And these are live links, I believe. The first link is to my youth suicide prevention intervention page on the OSPI website. And there's detailed information on that site about the behavioral health navigators, a link to their contact information by region, and more description of who they are, what they do. I've also included resources to support safety in schools, our social emotional learning webpage, and our CARE link. CARE is a Moodle course that we offer to anyone who would like to access it. It's just some strategies and skills for working with students in emotional distress. And it stands for Confident Action by Responsible Educators. And then I've included the DOH resource for suicide prevention in the workplace. That would not probably be on a presentation I do for the education world, but I thought that would be helpful for you all. So that was fast and furious. So there is my contact information, and I'm going to unshare my slide, my presentation, so that we can have Q&A. It looks like someone unshare. No, let me unshare. There we go. Stop share. Okay, so if you all want to unmute, and it is open for Q&A.
Have you seen, and you may have mentioned this, but has there been a marked rise in suicide since the pandemic started?
That's an excellent question, Troy. And just yesterday, I sat in a presentation with a legislative, one of our legislators and the Department of Health. And they did a very comprehensive presentation around just that, suicidal death by suicide data. And because of the lag time with the Department of Health and how they collect that data, they can't confidently say, they don't have hard data to share that there is an increase to date. They did share that we are about equal to the number of deaths by suicide, and this is across all ages, currently, and we haven't completed yet. And this I believe there was a 3-month lag, so that data was collected in September. We were close to the total number of deaths by suicide in 19. So that alone will tell you, yes, more than likely we are going to see a significant increase. Another source of data that suggests that we are is, I work closely, as I mentioned, with Forefront, and they are having an increased amount of requests for postvention support from school districts. That's the data they give us. And so that is also not hard data, but we believe, yes, that we are certainly seeing a high level increase in students experiencing emotional distress through the screening tools that we use in school districts.
Right. Yeah, I've even seen it in my grandkids. They're having a hard time being home all the time, and they've been sleeping. Their sleep patterns are off.
Yes.
Yeah. So.
Yeah. It's, we're seeing depression in little kids, small children. Very, very sad. Yeah. I heard recently that the youngest reported death by suicide was a 3-year-old. And
wow.
that just, just
That's
crushed me. Yeah.
My granddaughter has said, Grandma, can I come and look at you through the window? I'm just like, that was
Yeah.
at the beginning of all this, she just like, I want to see my grandma.
Yeah. Yeah. It's extremely difficult. Extremely difficult.
Yeah.
Any other questions? I have a couple questions for you all, if you don't mind, but I want to make sure any questions that you have are addressed first. So in your roles, and I know they vary, what challenges do you face specifically related to our current reality? And that's encompassing, the pandemic, racial and political unrest, and then if you're working specifically with problem gamblers, how is that all unfolding in terms of challenges?
I actually saw some people do really well through the casinos being closed. I had a handful of, a significant number of people that had their first taste of going periods of time without gambling. And in that respect, it was positive.
Mm-hmm.
One thing I've also found is that I gotta, and I always have, but you gotta be really careful. Keep your cards close to your chest about what you believe about certain things, because people are really sensitive and touchy. And if you don't believe like they do, they might get angry. And I had one client, I'd kind of let a little bit of something slip one time, and they called me and said, look, I can't receive counseling from somebody that believes what you believe.
Mm.
And I felt, well, that was unfortunate. And this particular person was in the nursing field. And I said, well, I hope that you don't treat your patients any differently based upon what they believe about, certain things that are happening in our society today. And she said, well, I don't. And I said, well, neither do I. So, but farewell, if that's the way you feel. I mean, there's not much I can do about it, but man, people are really touchy. And so you got to be careful.
Yeah. Yeah, people are very sensitive right now. And I know from my experience as an addict, touchiness is a characteristic of addiction. I mean, there's just I know that if I was approached about a certain topic at a certain time, that, if I was agitated in any way, it would go left very quickly. And that's something that is wonderful about recovery, is you have the awareness of those personality characteristics that were extremely prevalent during addiction. Anyone else want to share your challenges?
Well, I think that it is, if we're going to kind of look at the gambling population in terms of the families as well, but the compulsive gambler, is that there's, that need for that connection, that because of the isolation that occurs.
Yeah.
And GA, that's part of why I mentioned it. GA, not in its traditional sense, right? And they haven't really sanctioned for some people, people believe, to do the Zoom meetings or whatever their beliefs are about it. There's not that connection. And then you're not getting that connection socially with other people as well. And so that isolation reminds them of their gambling. So people are really struggling with trying to use their resiliency in this time, right? And even people who have strong resiliency is being tremendously challenged.
Yeah.
Right. So I'm finding even the slightest, like, the governor mentioning about the holiday right before Thanksgiving and saying, let's do the shutdown, the increase in anxiety, wanting to gamble, couple relapses, the depression just shot up. It was in tandem with any slight difference of, oh, here we go again, right?
Okay.
And emotionally being able to regulate that has, over time, there's only, so much you can manage if that's a skill you haven't really strengthened to begin with,
Mm-hmm.
right?
Mm-hmm.
Depending where you are in your recovery.
Right. Right.
So yeah, it's tough.
It sounds like the isolation has been a huge challenge, specifically in problem gambling. And that makes sense, because, that's a characteristic right there is many gamblers, go and isolate in gambling. And so there's kind of a catch-22 that there, and some don't, some do the opposite. It's their social outlet.
Right. Right.
Yeah, and I've heard quite a bit about both, Gamblers Anonymous as well as Alcoholics Anonymous, and just the challenge with Zoom and the connection with people. I know GA, from what I've heard with my connections, there's not been as many opportunities in the GA world for Zoom as there have been, from my knowledge, in the NA and AA world.
Right. Well, they've got the international too, but part of it is, part of the characteristics I see more with compulsive gamblers is I don't trust the world, right? And that kind of, so here I am on Zoom, where's my confidentiality, my privacy? I don't want to show my photo, or other people aren't showing their photo. Who are they really? Where are they? I mean, it just stirs up more anxiety.
Yeah, that's so unfortunate. Hopefully we're on the upswing of all of this. It looks like Gary mentioned that technological connectivity has been a big issue for clients on the reservation. Is that specific, Gary, to accessing things like GA and NA and the 12-step? Yes. Okay. Yeah. So if you don't have technology, and you can't access, so you have no outlet for what has been, in many cases, a primary support for staying out of the casino. Yeah. Oh. Have any other questions bubble up? How are you feeling about support with youth and families? Do you feel like, are you hearing a lot? That's more of a curiosity question for me, from youth and families in terms of supports. Has that increased? Or, well, many of you are working with problem gamblers, so you may not be seeing a lot of youth, hopefully. Knock on wood on that one.
I am hearing a lot from my problem gamblers about the stress of trying to be teachers at home.
Yes.
And that's adding a lot of pressure to some of the families. Many of the ones I talk to, they're just not equipped for this kind of thing, and so there's been a lot of here they talk about behavioral issues in the kids, because they don't know how to respond either.
Mm-hmm.
So.
Yeah, we've got parents who are, as I mentioned earlier, we've got parents who, let's keep addiction and recovery over here. Don't even add that in. And we've got parents who are struggling potentially with, their job being virtual, teaching their children, dealing with their children's mental health issues, financial worries on top of it in many cases. And then if you're struggling with an addiction, you throw that into the mix. We all know that the tolerance and just stability of someone struggling with addiction is different. And kids are very needy, especially when they're trying to do something they've never done before. And parents are trying to be teachers, which they're not equipped to be. We hear a lot at OSPI about the issue of, the struggle that parents are having we've put out lots and lots of publications and guidance for parents, and we filter that through the school districts. But that, many times parents, whether you give them guidance, they're not equipped to teach children. It's a skill set that's learned, and it's extremely difficult. So, yeah. And
Hi,
someone
Ann.
mentioned, yes.
Hi, this is Michelle. We have about 2 minutes to close.
Okay, great. I'm just noticing a comment in the chat. One of our participants was on the phone with a client meeting their needs. So thank you for sharing that with us. Well, we have 2 minutes. Any lingering questions? If not, I just want to thank you for being here today. And it was good to see some familiar faces. And feel free to, you have my contact information anytime, shoot me an email. If you need resources around suicide prevention for youth, I am right there for you anytime.